Okay. Well, welcome everyone to today's webinar. The purpose of the webinar is to go over the required hospital quality measures that are assigned to your hospital type for the Medicaid Provider Hospital Provider Fee Program. These measures are required to be reported on a yearly basis. This webinar is for the hospitals that are LTACs and freestanding rehabs. The measure for this type of hospital is discharge to the community post-acute care. As we continue our work with the hospital quality measures, this session is designed to ensure you have a clear understanding of the specific reporting requirements for this measure and to address any questions you may have. The Zoom meeting today is being recorded and we will have it available on our Nevada Hospital Association YouTube channel and our website. Please note that updated templates were emailed out and are also attached to this Outlook invite. The information that was changed on the template was only the instructions page with corrected emails and how to submit your completed measure. Today we have with us Lisa and Sherian from Mercer, and they're going to go over the quality measure that is assigned to your hospital type. So with that, I'll turn it over.
Awesome. Thank you, Jan, and thank you everyone for joining us. My name is Sherry Ann Thompson. I am one of the senior medical consultants here at Mercer. I am clinical by trade. I'm a registered nurse. I've been a registered nurse for about 15 years now, and have worked really close with various states and managed care organizations. I'm accompanied today by my colleague, Liza. I'll let her introduce herself as well.
That, excuse me. Hello, I am in South Georgia and the pollen has arrived. The last 2 days I have felt it. I'm Liza Ottorino. I am an associate here with Mercer, and this is my second year on this project. So some of you might know my name from submissions last year. I'm going to turn my video off though because I will share the PowerPoint and my computer doesn't like me to do both. So I will let Sherry Ann take it over. Give me 1 second and I'll have the PowerPoint up.
Awesome. Thank you, Liza. All right. So again, welcome everyone to our Discharge to the Community webinar for the 2026 program year. Today, we're going to break down how to bridge the gap between clinical success at the bedside and accurate reporting on your claims. If you have any questions during the presentation, feel free to post them in the chat. There is a frequently asked question portion where we'll do a little bit of Q&A. We'll go over some previous questions, and then if there's any questions in the chat, we'll address it at that time. Much of this information today may feel familiar, and it may just be a refresher for your seasoned team members, but this can be used as an excellent foundational training for your newer staff. Since we are recording the presentation, like Jeanne said, you will be able to easily pull this up and use it as a standard training source for future hires whenever you need to. All right, next slide. Thank you. So this measure comes from the IMPACT Act, and it is designed to see if we are actually helping our patients sustain recovery once they leave our doors. It's important to remember that this is a claims-based measure, meaning CMS is looking at the billing data to judge our clinical effectiveness. Next slide. All right, so discharge to the community is a high-stakes metric for various reasons, mainly because it is reported on Care Compare, and so it directly influences your patient referrals. But beyond reputation, failing to report this data accurately could result in a point reduction in your facility's annual payment update. So accuracy is literally tied to your bottom line. All right, so this is a super important measure. Next slide. So let's define your population. Who's in your denominator? So we're looking at Medicaid beneficiaries that are ages 18 years and older. Their discharge status should be patient discharged from the long-term care or rehab facility to a community setting, and they must have continuous Medicaid enrollment for 12 months prior to admission and 31 days after discharge. So who's in the numerator? How do we get a success? This person is discharged to home or self-care with or without home health aid. They've remained alive for 31 days post-discharge and had no readmissions to the hospital or another LTAC within 31 days. Okay, so again, to count as a success, Medicaid patient must be discharged to a community setting, stays alive and out of the hospital for a full 31 days, and if they are readmitted to an acute care hospital on day 30, then that encounter becomes a failure for this measure. Okay. Next slide. So understanding your exclusions. Exclusions are our way of ensuring that the data is fair by removing patients whose outcomes are outside of our control. So like those that have like interrupted stays, for instance. All right, so this is vital that your documentation reflects these specific scenarios so these patients don't incorrectly pull down your success rate. So let's go through some of the exclusions. The patient status. If your patient died during their stay, they would be pulled. They'd be excluded from your denominator. Non-compliance, if they left AMA. End of life focus. If the patient was discharged to a hospice program or facility, they would not be in your denominator. Like I mentioned before, interrupted stay. If they were transferred to another LTAC or our IRF, which we call that a sequential PAC. If they transfer to a federal hospital or court law enforcement, they would not be included. If this was a planned short-term acute care for a non-surgical treatment of cancer, again, that's an exclusion. So look at this flow chart, or I'm sorry, look at this table as a roadmap for cleaning your data. Okay, so again, specifically note how we have hospice and AMA discharges that are excluded. If a patient transitions again to end of life, like hospice care, these are your only ways to protect your facility from being penalized for a mortality event. All right, so exclusions are really, really, really important. Next slide. Okay, so this flow chart shows how a patient moves from your facility to the final report. The key decision gate happens after the discharge. So this is where we decide whether this was a success or not. If the patient survives the 31 days without an unplanned hospital stay, you've secured a win for your facility score. Next slide. So since this is a claims-based measure, your clinical and coding teams must be perfectly aligned. We recommend a monthly cross-check to ensure that what the nurse writes in the chart as home matches the specific discharge status codes being sent to Medicaid. So some of the focus areas would be, again, the discharge status codes, prior stay linkages, post-discharge surveillance, and hospice and AMA documentation. So these are some key focus areas that you and your team should be working on a monthly basis. Next slide. All right, so let's talk about some common data capture pitfalls. The biggest pitfall is the 31-day blind spot, assuming that a good discharge stays that way. Be wary of what we call ghost failures, where a patient goes into the ER weeks after leaving you and it goes unchecked or unnotified. So internal tracking templates often can miss these unless you have a robust follow-up process. So that's going back to your focus areas and when you're meeting with your team on a regular basis. This is how we make sure we catch these things. Next slide. So these are the frequently asked questions that were submitted from prior program years. So I wanted to just address these in case they were still questions that were out there. And so I'll read some of these questions and we'll answer them, and then we'll look and see if there were any questions from you guys today. All right, so first question is, what is a freestanding rehabilitation hospital? For Nevada's private hospital assessment, related UPL payments, and the SDP tied to these performance measures, rehab hospitals are classified as such in the initial NHA model and in all subsequent state-generated models shared with the NHA. What is the definition of community discharge? CMS defines a successful community discharge as a patient being discharged to the community and not experiencing an unplanned rehospitalization or death within 31 days of discharge. The community is defined as home or self-care with or without home health services. And then lastly, should patients who exhausted their Medicaid benefit be included? Patients who exhausted their Medicaid benefit during the LTCH stay should not be added to the numerator or denominator based on the CMS Partnership for Quality Measurement Exclusion criteria. All right, so I'll take a pause to see if there are any questions today on discharge to the community. Feel free to come off mute, or if we have any in the chat, I'll address them in the chat as well.
I don't see anything in the chat right now.
Okay.
This is Mark Moore from Dignity. I represent Dignity Health Rehab Hospital. So just to confirm on the community discharge. So if a patient, let's say their home is an assisted living facility or a personal care facility, that qualifies as home, correct?
Let's see. You're saying if they are going back to a home health,
If a patient is, I'm just going to make up something. Let's just say 68-year-old patient that lived in an assisted living community, not a nursing home, but an assisted living community or a personal care setting, like a personal care apartment, both those types of locations would be considered home because that's where they
correct.
reside. So
Yes, you are correct. Where it wouldn't be is if it's a skilled nursing facility. Now that's different. But if you're saying it's assisted living, yes, that is considered the member's home. You're right.
Thank you.
Great question, Mark. Thank you. So yeah, not a skilled setting, but assisted living is fine. Yes, that's considered home. All right. Next
Any other
slide.
questions? Oh, sorry. Go ahead.
Yeah, good.
No, I thought you were all done. Go ahead, please.
So how can we help? You guys do not have to navigate these technicalities alone. We do have support for you. If you have a state-directed payment question, that would go to Ann Jensen. And then if you have questions about reporting template or clinical support, that would be myself and Liza. All right, and so we have our email addresses listed here. So you can reach out directly to us. There's no middleman. You can reach out, and I'm super informal. Say, hey, Sherry Ann, I got a question. Feel free to reach out to me. We can set up a 30-minute one-on-one if you need to talk through some clinical strategies. I'm here for that. And if you have any questions about reporting template, Liza is here for you as well. Next slide. So some key takeaways to wrap this up. Success is a 31-day commitment. All right. So remember, no readmissions or keeping the patient alive within that 31-day window. Coding is your performance. So making sure that the data team and the clinical nursing team are one. You guys are speaking the same language and we're all on the same page. And then remember those exclusions, they are your friend. Getting those exclusions down pat and making sure that you guys aren't doing yourself a disadvantage there. All right. So if you got, again, I'll pause again if you guys have any questions. I know a lot of this information you probably already know, but this will be a great slide if you have any new people on staff that are not familiar with this measure, discharge to the community. They can go through it. And then if they have any questions, again, we are here for you guys to email us directly. And like Jan said, this will be posted to the state site and the recording will be posted to their YouTube. Jan, correct me if I'm wrong. I think they said it was going to be on their YouTube channel. Yes. Okay. All right. Any closing remarks from you, Jan, before we go?
Just thank you so much for today and the really valuable presentation. I appreciate the questions too. That was really great. And again, like we said, it'll be available on our YouTube channel and website. And once it's posted, we'll send out the links. And thank you so much, everyone, for joining us today. Take care.
Thank you.
Thank you.
Thank you. Bye-bye.